Hi, everyone. Thank you so much for joining us this afternoon. So we're going to get started. I'll be your moderator for today. I'm Dr. Sundaraj. So our oral presentations today are going to focus on collaborative and integrated care. Before we start with our first speaker, I'm just going to have everybody hold their questions until the end of the session so that we have a more robust discussion at the end. But without further ado, let's get started with Dr. Joy Choi, who's presenting embedding primary care clinic within community mental health services, reduces all-cause hospitalizations and emergency department visits for patients with severe mental health illness and cardiovascular disease. So without further ado.
Yes, I realized that long mouthful of title is probably not the best. I rebranded my talk much more simpler. Thank you for coming. My name is Joy Choi. I'm at the University of Rochester Medical Center. I'm the embedded transplant psychiatrist for the Advanced Heart Failure Service. So my interest is in patients with cardiovascular disease or at risk of it. I have nothing to disclose. So today we're going to talk about the importance of being able to create really accessible and excellent primary care for patients with serious mental illness, and kind of briefly reviewing the models that's been tried so far to be able to cater to their needs, and really talking about the potential impact that this particular model, reverse integration model, could have on care utilization in this population. I don't think it would be a surprise to any of us here to know that cardiovascular disease is a significant burden for patients with SMI. They have up to approximately 20 years of reduced life expectancy compared to a healthy population. And about 1/3 of this reduced life expectancy is estimated to be caused by cardiovascular disease, a lot of it preventable, and which in turn poses a high amount of healthcare burden from just generating cost and needing treatment. We know many reasons why they have higher risk of cardiovascular disease and disease burden. Many of it relates to their illness itself, where it leads to more sedentary lifestyle, increased rates of smoking, the psychotropic medications that we're giving that causes cardiometabolic syndrome. But at the same time, there's also responsibility on the healthcare part, us as providers and as systems, where the system is not really set up to understand their needs. A typical primary care clinic office is not going to be well equipped to help patients who are coming in with maybe low-grade or full psychotic symptoms and really have difficulty engaging them in treatment or have the time to engage them in treatment that they need. So many things really lead to the data that we see here. So traditionally, we've brainstormed as a profession, as a country, at many levels, how do we make this more effective and streamline and provide the care that they need? And this is probably very familiar to you, the traditional collaborative care model, where the patient is at the center and there are care managers and psychiatrists as consultants who are involved in their care to help them manage and really understand the patient's needs. But the Cochrane Systematic Review in 2013 have revealed that generally collaborative care models whose results are published in the literature really don't have a statistically significant reduction in either cost or care effectiveness when you measure metabolic risk factor outcomes. So in our hospital at the University of Rochester Medical Center, we have a very unique model, a variant of collaborative care, depending on how you describe collaborative care model, reverse integration, which we're defining here as we are actually co-locating a primary clinic instead of embedding a psychiatrist in primary care. This is how locating primary care within Department of Psychiatry. It's a division run by dual boarded physicians in psychiatry and medicine, or just internal medicine or family medicine practitioners who are interested in providing care for patients with SMI, which is physically located and run by Department of Psychiatry in the same building in a suite adjacent to the psychiatry clinic that caters to patients with SMI. This is a model that's very little known in the literature. There's really not much published on the effectiveness or how this works. And it's also really valuable that I'm presenting to you data from a real life model, as in this is not some grant funded protocolized system where you know that there's a challenge in replicating that in general clinical settings. So what's unique about the service being provided here is that, again, the patients and staff work here knowing that they're going to see patients with SMI. They're very interested in and have a heart for this population, and they're also given the resources to do so. For example, the clinicians, the primary care providers have 1 hour intake and 30-minute follow-up, which that really is much longer than how you would see, and they see them more frequently. I'll say at least once every 3 months, which we know does not happen in the general population. And they have interventions provided for patients with CVD risk factors, including one-on-one smoking cessation counseling that they're encouraged to engage in, meeting with pharmacists to talk about their statins and diabetic medication adjustments. So just really more targeted approach that they're being given all wraparound care. And they also have on-site lab and pharmacy services. We all know how hard it is to tell our patients to go get their A1C drawn or pick up that medication, or even check that they picked up the medication. All this adherence and giving the resources to patient is made much easier so that they don't have to travel to places. So this begs the question, does the treatment at this particular treatment model, reverse integration at MIPS, does it lower healthcare utilization for patients with SMI and CVD? Because again, we know patients with SMI and CVD drive a high care of cost burden. And we are trying to answer this question by looking at, I know it's a busy slide, but essentially it's a big claims data analysis. So we're able to obtain claims data from Common Ground Health, which is an organization that pulls data from private and public insurances. And what we did is we looked at people who had received care either at MIPS or at not MIPS primary care, but also had a psychiatrist and had SMI and CVD. And we try to compare their acute care utilization rate, compare from before to after. So they needed to have had at least 6 months of not having had any medical care through a primary care office. And then we define their enrollment date into the program, because this is, again, large data. We don't have individualized data, by looking at when their first bill claim was for treatment at MIPS or non-MIPS provider. And then we saw how their utilization claims showed for the past 6 months after and then thereafter, to see kind of like an acute effect and then more chronic effect. So just to bore you with statistics, we couldn't compare the MIPS group directly with the non-MIPS group, because I'll show you in the next slide, they're so drastically different at baseline. So it's apples to oranges. So what we had to do was, knowing that there is already such difference, like the red and the green light, we had to, instead of compare the two groups, compare what the MIPS groups statistically projected to have done after enrollment at MIPS versus the actual observed care utilization rate. This will become more easier to understand. Sorry, I didn't realize it would come out so small, but essentially this shows you about, there were about 10,500 non-MIPS patients in the comparison group. And then the MIPS, there were a little over 1,000 patients they were able to identify, and they're super different. So patients who got treated at MIPS, they already at baseline before enrollment at MIPS had much higher ED visit rate, much higher inpatient visit rate. This is all cause visits. They were more likely to have Medicaid compared to the other group. They were more medically complex, much higher Charles comorbidity index, and also much more likely to have substance use disorder, which is, again, why we really can't compare the two groups. So when you compare the MIPS group, what we observed after enrollment at MIPS compared to what we expected them to have done had they not enrolled at MIPS, we see that there is a trend in reduction in both ED visits and inpatient hospitalizations. So you can see that the percent difference in the first 6 months after what we deemed them to have enrolled in MIPS is negative 16%. And then post 7+ months out is about 20% reduction in utilization rate. And that 7 month beyond is a statistically significant result reduction. Acute inpatient admission, again, these are all cause admission rates or visit rates, doesn't have significant reduction, but you can see the trend is the similar, about 20% reduction in the first 6 months, and then 28% reduction all cause inpatient admissions after 7 months. So what does this really mean? I mean, we know that this is a real life model, so it's in works. It's working already within the existing very complex broken system, and somehow it's still making a difference on data analysis. We do have a relatively large sample, and we know we're capturing a wide array of patients, wide array of socioeconomic, Western New York, all those states, there's urban areas, rural areas, so we know that this is generalizable to many different populations. And we're also not limited to a single healthcare organization because we're looking at claims data, not an internal hospital data. But at the same time, because it's a claims-based data, we're missing a lot of individual level data. We can't really connect this to their clinical efficacy of this model, where we don't know what their A1C reduction is. We don't know what their rate of, lipid reduction is. And so we also don't know that what we defined as enrollment date in MIPS is really when they truly enrolled and then continue to have care. It's hard to really compare that without the individual level data. And also it's rather unique. I mean, I mentioned this is a really unique setting, which is its strength, but at the same time, that also makes it hard for you all to bring it back to organization and then try to get it off the ground. So in conclusion, we have some evidence that reverse integration can aim to improve access to primary care with patients with SMI that offer some reduction in all-cause ED visits. But we would ideally want future studies that look at direct cost effectiveness instead of just this estimation, and the actual specific reduction in disease burden, and also being able to tell perhaps apart medical admission versus psychiatric admission, because this is all cause visits. Hard to tell how much of this was driven by cardiovascular disease versus something else that they may be driving their healthcare use. So just want to thank all the co-authors who helped me analyze data and write this up, and our providers at MIPS. And I unfortunately have to run to another talk. So if you have any questions, kindly do shoot me an email and I'm happy to answer, unless I don't know how long it's been. Yeah, all right. Thank you so much.
Thank you. So next we have Dr. Joseph Ciaramella presenting on the effectiveness of outpatient CL models for bipolar disorder in primary care.
Hello, everyone. My name is Joe Ciaramella, and today I want to present to you the results of a secondary analysis from a clinical trial that many of us worked on, including Dr. Amy Bauer, who's here present as well. So I have no disclosures, and I'll tell you a little bit about the rationale for this. What I'm trying to do is compare 12-month outcomes, 12-month treatment outcomes for individuals diagnosed with bipolar disorder in two different models of care in primary care settings. One's called collaborative care, the other is co-located care, and I'll tell you about those models. And then we'll also report medication treatment patterns for patients who were treated in each study arm. So a couple of points about background. I mean, I often get asked about bipolar disorder in primary care. Why bipolar disorder in primary care? Isn't this a specialty disorder? Why think about this? And I think there's a couple of different ways to view this. One is that there's clinicians already doing outpatient CL models in primary care. I've met several people here who are already doing this work. And if you're doing this work, you know it's very difficult and probably not possible to restrict a group of patients to major depression or to generalized anxiety disorder. There are other disorders, other diagnoses. You might learn something new about people that informs diagnosis. In clinical practice, this will come up and does come up regularly. It comes up in direct care, comes up in co-located care, collaborative care, and so on. And patients, the other way to look at this is thinking about where people with bipolar disorder go to seek care. And over a 12-month period, we could see, especially with bipolar 2 disorder, with similar colors in the dark or similar proportions in the dark blue and the light blue, that's a similar proportion of people going to seek care from psychiatrists compared to primary care physicians over a 12-month period. So part of it is clinicians are seeing this regularly, and part of it is thinking about the clinical epidemiology. Where are people actually going? And so that's why I think about bipolar disorder in primary care. but it raises a question about how might one as a clinician approach these individuals? How might one treat patients? And there's two ways that come to mind, and it's exactly two ways that we tested in a larger clinical trial. One is collaborative care, which we all know, many of us know, population-based, uses a registry, promotes use of measurement-based care. There's care manager. Dr. Choi just mentioned collaborative care in the prior presentation. Not as much of a need to define what that is, but it's a practice that we're doing, and it's something we used in a clinical trial. And the other is directly seeing a patient in primary care. I'm a psychiatrist. I might see a patient directly in a primary care setting. That's another integrated care model, another way of thinking about taking care of people with bipolar disorder in primary care. One other point I'll mention is that in a direct care model, I might prescribe the medications directly for the patients. And in collaborative care, the primary care physician would end up prescribing medications for patients. And I mentioned that point because I have one slide about medication data, but we don't know which model's better. What if one's better than the other? We might want to put our resources into one model versus the other. We might have hypotheses about what's better or not. So the data that I'm presenting today comes from a larger 12-month treatment clinical trial that was called the SPIRIT study that we published results on a little over a year ago. This was a pragmatic trial. It recruited people who were screening positive for bipolar disorder and/or PTSD, which is not equivalent to diagnosis, but it was based on screen positive status. And the major outcome from this trial, I mean, there's a lot that goes into this trial, but to get onto the secondary analysis was that participants in both arms getting treatment with collaborative care or getting treatment with co-located care improved significantly. Treatment worked, and it worked similarly in both arms. It was interesting. And so again, these were people who were screen positive for bipolar disorder or for PTSD. And what we found from the sample of about 1,000 people was a smaller group of people who were actually diagnosed with bipolar disorder by a psychiatrist. And that's the sample that I'm talking about for this secondary analysis. So we had, like I mentioned, 1,000 people in the trial, and we found 191 diagnosed by a psychiatrist with bipolar disorder. So it raised the question of, when we looked at a larger sample, maybe the effects that were more specific to bipolar disorder were sort of diluted by the larger sample, and maybe there's a difference in secondary analysis that we could look at and observe. And what were the medication treatments by arm? So I'll tell you, we identified people diagnosed with bipolar disorder based on psychiatrist assessment, consultation, diagnosis, and we looked at baseline data and 12-month outcome data. We looked at demographics. The primary outcome that we were looking at was called mental health functioning, assessed using the RAND 12-item MCS score, the mental health component. We also monitored or measured depression symptoms with the SCL-20, and we also assessed some clinical data. So the first 2 points were baseline and 12-month research survey evaluation data points. We also had some clinical data, and we used sensitivity analyses looking at health center and bipolar disorder screening status. I'll mention in the larger trial, we were working in 14 different fairly qualified health centers. So that's partly why we did analyses by health center as well. Some high level results, table 1 type results. People diagnosed with bipolar disorder had a mean age of about 40. Gender, ethnicity, race distributions shown below that. Interestingly, I think down at the study arm, there was a greater number of people diagnosed with bipolar disorder in the collaborative care arm compared to the co-located or direct care arm. Again, the randomization was based on screening status, so it's not really clear how to interpret that. One idea, I have some ideas about that, and if there's time, I could answer a question about it. And I'll move on. Some baseline, I have this baseline outcome measures in the next slide as well. I'll just move on to that. So the results, what we found was, I'll interpret some of these numbers here. So the top measure, the VR12, was the primary outcome, which was low at baseline. I mean, this was a value that was lower than many of the other primary care depression clinical trials, showing low mental health quality of life. And we found this actually the same thing as in the primary study, that in both arms of the trial, the primary outcome improved and was not different between arms. Likewise with depressive symptoms, which improved in both arms in the second row there, the SCL, and with anxiety symptoms and a measure of recovery called the RAS. So improvements in both arms that did not differ by arm. It's interesting. One might have thought, direct care by a psychiatrist might be associated with better outcomes given the diagnosis here, but we didn't observe that in this trial. And I'll show one other slide or one other figure from clinical data. This on the right comes from observations with patient-reported symptom measures, one called the PHQ-9 for depression, the other called the PMQ-9, patient-reported manic symptom measure. And at baseline, in the light-colored bar, we saw a very low number of people with low symptom burden. And a high on the right side, a high number of people with high symptom burden. And we saw a shift over time in the dark bar to a greater proportion, almost a third of people with low depressive, low manic symptoms at the final clinic visit. So we saw improvements in our research assessment, but we also observed that during the clinical treatment as well. And I'll make a couple of comments about medication treatment. This came up as questions yesterday during a session about this trial. Again, there were two differences, or one difference between the two arms. In the direct care co-located arm, psychiatrist was seeing patients, prescribing medications, and in the collaborative care arm, the psychiatrist would give recommendations to the primary care clinicians who would then execute the medications or not. So we wondered if there might be differences between the arms. We actually ended up seeing similar medication treatment patterns across arms. One thing that was interesting, there was essentially no change in any antidepressant use. It's commonly, almost half of people in the co-located arm receive treatment with an antidepressant. It's interesting. It's very consistent with national data on outpatient treatment of bipolar disorder that's come out in the last year or two. However, unopposed antidepressant or antidepressant alone did decrease in both arms. And then one other finding, this is, I think, a replication from a finding that came out a year ago. Lamotrigine use seemed increased more so in the collaborative care arm. Maybe a more feasible medication, maybe a more approachable medication for some clinicians. Second generation antipsychotic use increased throughout the trial in both arms, and lithium treatment was just low in both arms at baseline at 12 months. It just wasn't a commonly used treatment, at least at 0 and 12 months. We don't know if it was tried in between that from this data set. So a couple of conclusions. One, this is a secondary analysis from a trial, so these are not definitive results, but it's looking at a data set that we collected during a larger clinical trial, and it showed similar improvements in both arms, no difference in either arm. One wonders if use of telehealth, the treatment in this trial was delivered through telehealth, did that perhaps influence decisions about lithium use? It's a consideration. One other limitation, there was no usual care, no control arm. So I think a couple of concluding statements here, more so about treatment. If you're already doing collaborative care, or if you're already doing co-located or direct care in primary care settings, there's some evidence that you can do this for people diagnosed with bipolar disorder, and you can be hopeful that you can see improvements in a primary care setting, given that we saw similar improvements in both arms and similar medication treatment patterns. So I'll stop there. Thank you.
All right. Next up, we have, too short for this. Next up, we have Dr. Christopher Placia talking about a collaborative multidisciplinary model for complex care management across medical psychiatric spectrum.
Thanks.
Hi there, I'm Chris Placia. I am coming from the University of Pittsburgh in Pennsylvania. And I'm gonna talk about a unique collaborative care model that I help out with. I'm actually a rather small part of it, and just describe our program and a couple outcomes. So that's me on top, and then this is the corresponding other authors who are not here with us today. I have nothing disclosed and they have nothing disclosed at all. So a little background, super utilizers comprise 5% of patients, but use over 50% of healthcare dollars. This population often receives lower quality of care despite their frequent visits to the emergency department and admissions to the hospital. Many times these patients suffer from untreated mental illness, have financial difficulties and comorbid medical illnesses. They particularly have difficulty navigating the healthcare system independently. Providers struggle with this population as their needs cannot be met in infrequent 15 to 30-minute appointments. Furthermore, payers struggle with the increased cost burden of these said superutilizers. So traditional models of care, unfortunately, do not meet the complex needs of these superutilizers. One alternative system, the patient-centered care medical care home model, was developed as a means to provide highly coordinated primary care by using a team-based model with frequent patient check-ins and case management. Evaluations of this model in medical practices, however, have shown limited effects on the quality of care for superutilizers. A growing call to attend to this marginalized population has led to the implementation of novel models of care, such as ambulatory intensive care programs. So here comes our program to try to address this problem. So in July 2014, the University of Pittsburgh Medical Center, that's UPMC, and the health plan, we'll call it HP for these purposes, and our academic medical clinic, GMO, General Internal Medicine Clinic of Oakland, partnered to create what we call the ECP, or Enhanced Care Program. This is intended to address the needs of said superutilizers, specifically in this clinic and in our ER. So the goals of the ECP really is to provide high quality care and decrease the use of healthcare resources and healthcare expenditures across the health plan. So who comprises of the ECP team consists of primary care physicians, 1 and 0.1. So that's two doctors doing that, 1 full-time, 1 half day a week, several nurse care managers, a dedicated full-time social worker, an administrative assistant, a consulting LCSW psychotherapist that also works with me in my integrated care clinic, and then me as the consulting integrated care and CL psychiatrist that meets with them on a regular basis. So what is the structure of the daily team? This core team meets daily to huddle, where team members provide updates on patient status and plan for the day. Additionally, a monthly meeting happens to discuss the overall patient care plan and assess any gaps in care. The team also collaborates regularly across the system with our psychiatric hospital, our community care psychiatry programs, such as our CTT teams and our community clinics, as well as with the local pharmacy, and as well as community supports. Picture of our great team there. It's Jody Brick in the middle. She's the internist who leads our team, as well as some of the nurse managers and care managers there. So who are our patients? Patients from our clinic, the GMO clinic, are directly referred by the PCP, or we screen data from the health plan to get some of the patients into ECP. There are occasional outside referrals, such as from me or our other CL colleagues that we think might apply to the ECP. So to be part of the ECP, you have to be a superutilizer. You have to have eligible UPMC insurance, and UPMC has multiple different plans: commercial, Medicare, and Medicaid, and so areas. And you have to voluntarily be willing to participate in the program. They originally kind of tried to introduce people who didn't voluntarily want to come at first, and they had a lot of dropouts. Exclusion criteria is non-modifiable medical conditions such as advanced cancer, liver disease, other terminal illnesses, hospice-bound patients, and also people who primarily live in skilled nursing facilities. So more aimed at kind of chronic disease burden. So what services does the ECP provide? They get a full medical and psychosocial assessment in the beginning. There's a care plan created that's in our EMR, actually across two EMRs. So not only the ECP team can see it, but other outside providers. And this is a living document that can be updated by anyone on the team. And all patients must be seen monthly by at least one of the nurse care managers, or if not, the PCP. So our program discourages ED visits with specific, and we have a specific ED or inpatient care plan called the complex care plan that's can be visible by anyone in the healthcare system when someone is admitted. This plan consists of specific recommendations, including specific meds that have helped the patients in the past, with boundaries to help set with the patients, what meds not to give the patients, and contact numbers for the patient's providers and support persons. Instead, we try to direct these patients directly back to ECP. There is a 24/7 monitored health line by one of our nurse care managers. The ECP also has several unique characteristics for treatment, including a walk-in clinic that provides easy access to one of the main PCPs there, as well as we conduct home visits to accommodate patients who would otherwise just go to the emergency room. Clinic is equipped with for emergent blood work, fluid administration, EKGs, IV antiemetics, and non-opiate pain management. We can also help schedule necessary imaging the same day as well. So nurse managers and social worker help patients achieve their goals, to help them take better control of their own health, physically and mentally. For example, patients who have high blood pressure are taught how to self-monitor and educated how their diet may affect their condition. Same with diabetes. Some of the nurse managers and social worker even do home visits to kind of assess food in people's homes. So to improve med adherence, program works with a local pharmacy to deliver medications and blister packs to the majority of our patients. Adherence is regularly monitored by surveillance of these said packs. We also try to use injectable medications such as once weekly Duluga, I can never say it, diabetes medication, and LAIs if appropriate. ECP social work can assist patients with medication costs as well and connecting them to available coupons, budgeting, help them plan. So where do we come in? Here is I meet with them weekly for approximately an hour every week, and we run the list of their patients who do have comorbid psychiatric, substance use disorders, personality disorders, psychosomatic symptoms, what have you. And I help triage every week. Sometimes I make direct medication recommendations. Sometimes I help connect them to the right referral source, whether it's a community mental health clinic. Sometimes I help with involuntary hospitalizations as well. Many times I do one-on-one consultation through my integrated care clinic, which is housed alongside ECP, and see a lot of these patients one-on-one, do a full consultation, make a plan, and then hand them back to the PCP. Also, a lot of these patients utilize our LCSW psychotherapist and are seen on a regular basis for therapy. So that's me, and that's our therapist, Allie Kemp. So, like I was kind of alluding to earlier, many of these patients have a lot of psychosomatic conditions that brought them to the ER. We see a lot of non-epileptiform seizures, cyclic vomiting syndrome, and we have the ability to uniquely kind of co-manage together. Many times I'll see patients alongside the internist and kind of help co-manage together. Also, many times we see a fair amount of serious mental illness as well that our PCPs manage, and I help kind of manage from afar. So does this program work? I guess that's the biggest thing here. We conducted a chart review of baseline of pre-ECP data for all patients. Blood pressures were recorded during initial appointment. Patients with diabetes, the most recent A1C, as well as foot and retinal screenings. within last year were recorded. Status of screenings for colon, breast, cervical cancer were recorded. And also for patients who did have a comorbid psychiatric diagnosis, we screened if they had any connection to mental health care, and that was defined by at least one face-to-face visit with any mental health provider. So pre-post analysis was conducted for the patients enrolled in the program for at least 6 months, for whom both the data was available for pre and post. The data was collected from July 2014 to March recently, and 183 patients were picked at random. Significance of change was measured using the McNamara chi-square test for dichotomous variables here. So this is a general overview of the data here. I don't want to get too stuck on this, but the biggest thing here is the because we did not have a comparison group, the national benchmarks here, that we were pretty much spot on with the 90th national percent benchmarks, as well as kind of the trend here is the pre and the post data. The green indicates improvement from baseline. So to get a little more specific here, as we can see there, we have some statistically significant data and outcomes here in the diabetes cohort. Eye exam in the past 12 months and foot exam in the past 12 months were both statistically significant, though all areas did show improvement, including reduction of A1C below 8 and 9%. In the hypertension population, we saw all statistically significant reductions in both the diabetes patients that also had hypertension, as well as the just primary hypertension patients here, as we can see. And then screenings in general here, again, statistically significant for pap smears, colorectal screening, and connection to mental health care here. Was very significant from 38% to 99%, again, defined as a face-to-face visit with any mental health care professional. So the major limitation of this study is that it's a classic quality improvement methodology looking for a change over time. In of itself, pre and post, we did not have a control group. Therefore, these results must be viewed as preliminary. True randomization was not an option because we used the same patients pre and post here. Comparing intervention group to patients who were not chosen or did not choose to participate would have resulted in a biased comparison. But of course, given the promising outcomes in this pilot study, we are hoping to do a larger controlled study. So cost analysis, what's nice is the healthcare plan works closely with the health center. So the health plan ran an analysis, a little different date here from the inception of the program through 2019 to assess if our program's cost effective. There were 234 match pairs using bootstrapping out of 306 members at that time. So there was declines in unplanned care. Unplanned care utilization fell significantly by 320 encounters from 675 annually per 100 members. This was driven by a significant decline in emergency department utilization, down 263 visits from 448 annually per 100 members. While the decline in ER utilization generated statistically significant savings in ER cost of $114 per member per month, unplanned care cost overall did not fall significantly because the utilization reduction was driven by lower intensity, less costly encounters, driven by more ECP visits, home visits, etc. So there was a significant increase, though, in pharmacy costs by $314 per month per member of the ECP, worth approximately $2.5 million over this study period, the first 66 months. Total cost of care did also increase, but it was non-significant by $211 per ECP member relative to the comparison. Again, that extrapolates out to 1.6 or so million dollars over this study period. And here we just kind of have a chart kind of showing the reduction here at the top of unplanned care, both statistically significant of ED visits and overall unplanned care dollars. And then the red arrow is the increase of pharmacy costs, which makes sense with kind of a increased compliance with our outpatient providers. So conclusions, we have shown improvement in quality metrics from initial baseline among patients enrolled for 6 months. We believe this is due to more focus on preventative care and chronic disease management on a more intimate basis instead of utilizing the ER. This is fostered by close patient-physician relationships, a team-based model with close follow-up and excellent communication, and addressing social determinants of health, as well as addressing mental health and psychiatric illness directly through the primary care. So ECP has also shown statistically significant reduction in unplanned care and emergency department, as I just shown, but with that comes increased pharmacy costs. There's some more of our lovely team members on our recent trip to Niagara Falls.
All right, next up, we have Dr. Tom Zobler, who's going to be talking about improved mental health outcomes through phased implementation of technology-enabled behavioral health integration in patients with co-occurring pain and depression.
There we go. Okay. So pleasure to be here. So this is a study looking at a mobile health platform that is designed to integrate psychiatry and behavioral health into a whole range of medical settings. It's part of something that a tech company that I work with, Neuroflow, has. And we work with a wide range of health systems and payers. This was in a large pain program, multi-site pain program in Pennsylvania and Virginia, Pain and Spine Associates. We wanted to see how leveraging technology could improve outcomes in terms of the treatment of depression in this pain setting. So my disclosure, tech companies are technically not an ineligible company, but I did want to let everyone know this research is sponsored by Neuroflow. I am an employee, the chief medical officer of Neuroflow, and I have equity in Neuroflow. So very briefly, let me talk with you a little bit about chronic pain. We all know that it's incredibly common, affects 50 million people. We know that about 11 to 40% of people will experience persistent pain at some point over the course of their lives. And we know that it's highly interrelated with depression and anxiety, with depression causing much more intense pain, longer duration of pain. So it's important to address the two. We know that they are very disabling, depression and pain, as I think you're all familiar, I'm sure, with these statistics. And in fact, this probably underreports the disability associated with pain. ICD-10 has limitations in terms of the nomenclature, may change with ICD-11. We probably underreport pain and diagnoses and claims data. We know something about the interrelationship between pain and depression. We know it affects neuroplasticity. We know that the pathways for body pain that map to the same areas of the brain involved in mood regulation, mood management. We know that the amygdala, the central nucleus of the amygdala, can serve to either potentiate or mitigate pain response based on patient emotional state, context, experience, a whole range of factors. It really underscores the importance of addressing psychiatric illness in patients with pain. Of course, we have the opioid epidemic, which to a large extent resulted from the treatment of chronic pain. So again, underscores the importance of addressing pain with non-opioid alternatives whenever possible. Okay, so you all may be familiar with the AMA report that came out in April of this year. It looked at leveraging technology to integrate psychiatry and behavioral health into medical settings. It talked about this high-tech, high-touch approach, where it was a combination of using the technology along with clinicians in primary care and other medical settings to augment outcomes and to be able to scale these models of care. There was another AMA project, a study that came out recently that showed increasing levels of comfort and adoption of using technology in behavioral integration activities. So in this study, we looked at 2,808 patients in this multi-site pain program. There were two phases. The first phase lasted 2 years, and these were digital-only interventions. So the platform was designed to have patients assessed for depression. We looked specifically for depression. We were actually looking at other illnesses as well, but for the purpose of this study, it was for depression. And based on how patients scored, they were given resources, digital CBT, pain management resources, all digital interventions through this mobile health platform. It was AI curated, so it was all automated. And then there was a phase 2 of the study that was 1 year. That was a full bore collaborative care program that was tech enabled. So we had all the services, all the digital services that were in place for phase 1, plus there was a registry that's part of this platform, and clinical decision support tools for the pain docs who were doing the prescribing. That lasted 1 year. We defined response as a 50% reduction, typical description, 50% reduction in the PHQ-9 score, and remission was a score less than 5. So just to walk you through the numbers, again, we had 2,808 patients, about 40% were diagnosed, or excuse me, scored positively in the PHQ-9 for depression with a score of less than or equal to 10. 77% then responded with a greater than 50% reduction in score. And then we had 65% of those patients get additional PHQ-9 scores. And sorry, it's very hard to read this on the computer. And then we looked at remission, and 75% of those patients then went into remission of both phase 1 and phase 2 combined. And here you see the data, 40% of patients screening positive. We had mean average score or age of 56 years old. You can see the breakdown in terms of race. And again, 40% of patients screened positive for depression. Of course, those with depression were much more likely to have co-occurring medical diagnoses. You can see, in addition to their pain diagnoses, you can see some of the medical diagnoses listed here. And these were the findings. So we had in the first phase, again, it was 2 years, digital-only interventions. We had 780 patients who were in that first phase. The initial average PHQ-9, the index score for those who scored positive, was 13.6. 77% of those patients reached response within 22 weeks with an average score of 4.4 in the PHQ-9. And then 74% of patients reached remission by 24 weeks with an average score of 1.9. So that, what was particularly striking about this for us is that these were digital only interventions. Again, CBT, various other self-management resources directed to patients through AI. Phase 2, Phase 2, This was collaborative care, tech-enabled collaborative care. What we found is there were 374 patients in this part of the study that scored positively on the PHQ-9, score of greater than or equal to 10. 72% responded. So I'm sorry, the average score initially was 14.5, the index score. 72% achieved response within 15, let me just make sure that, 15 weeks with an average score of 3.7. And then 77% achieved remission by 17 weeks with an average score of 2.3. What was striking about this is the time difference. So the tech-enabled collaborative care group in phase 2 went into response and remission much faster. So you can see from this slide that the response remission for the phase 1 group, the digital only group, it took 22 to 24 weeks. That changed to 15 and 17 weeks in the collaborative care group. And that was the significant difference between those two groups. The scores, the decrease in the PHQ-9 scores was really quite comparable between the digital only interventions and the tech-enabled collaborative care. That was, we didn't really expect that the digital only would be as robust as it was compelling data for us. So one of the things that we were also struck by, not really surprised, that this pain program, they were doing screening with pen and paper assessments for depression, but they were only capturing about 8% of their patients with depression. With these automated assessments that were done through this mobile health platform, we were capturing 40% of the patients who in fact screened positively for depression. And what we also found is that when you compare the outcomes, they were pretty robust with the tech-enabled collaborative care in terms of patients who had a response, 72% within 15 weeks. When you compare it to collaborative care, traditional collaborative care models, not tech-enabled, when you compare it to BHI models, traditional BHI models, that response rate is a good bit higher than what you typically see. There may be a number of reasons for that. Part of it may have to do with the practice extension, that in between appointments, you can provide patients with self-management tools, clinical decision support, that the triage engine that is used here helps to identify patients who are at highest risk, where the most time and effort can be concentrated. So this, just to give you a little bit of background on the technology, this is the model. There are multiple inputs. There's remote patient monitoring. There are claims data. There are a whole bunch of data that goes into a triage engine that then in turn determines the level of acuity and can help direct patients to the appropriate level of care, whether it's collaborative care or if it's beyond collaborative care, whatever it may be. There's content-specific modules that patients will get for managing their depression or anxiety or a range of other problems. There's remote patient assessments. There's ongoing measurement-based care by virtue of this mobile health platform. One of the things that the technology allows you to do is to scale these models of care, collaborative care, BHI, on a much, much larger scale, and to be able to automate workflows and so on. And this diagram just illustrates the way that the platform can help to facilitate the traditional collaborative care model, that triangle. So there's the registry, so that the behavioral care manager, the BHCM, and the caseload supervising psychiatrist can communicate well, look at outcomes, look at all the critical variables so that they can maximize their time or work as efficiently as possible by operating on the top of their licenses. There are the self-management tools for patients, clinical decision support tools for the pain docs in this instance, to facilitate care. So in summary, what we found is 40% of patients were identified as scoring positively on the PHQ-9 for depression. We had a very robust response in terms of a 50% reduction in PHQ-9 scores or actual remission in both phases of the study. The collaborative care, the tech-enabled collaborative care, there was a much shorter time to response and remission. And again, when you compare the outcomes to traditional models, what we see is a higher level of response and remission than what you see in the traditional models of collaborative care. We're embarking on more studies, including randomized controlled trials, to continue to validate this research. But we thought we would present it here today. So thank you.
Right. So last but not least, we have Dr. Ralph Stewart talking about perinatal mental health coordination and monitoring pilot program for veterans.
All right, good afternoon, everybody. I got some tough acts to follow, but I'm gonna do my best. My name's Ralph Stewart. I'm one of the outpatient collaborative care psychiatrists with the VA San Diego healthcare system, along with some of these people that are also a part of this program. This isn't our primary job. We do collaborative care in a primary care setting, but this is something we do as a side. So all of these people either are part of the program or helped me put together the abstract and the presentation. So I really owe them quite a bit. Being a recent graduate from fellowship, I have no financial disclosures, but if you know of some, send them my way. I got some loans I need to pay off. So our veteran population is, the female veteran population is rapidly expanding. As of right now, it's at about 11% of overall veterans. It's they say it's going to hit about 14%, 14.5% by the year 2035. Being in San Diego, we're kind of located in a special geographic location with multiple large military bases in the area. So we get a lot of recent veterans recently separated, and it seems like a large portion of the female veteran population tends to be younger, and they are separating, and they are in that prime reproductive age to get pregnant, to have children, and to be breastfeeding. So that's why I think this is kind of a perfect area to get into this program. So being female veterans, all veterans have unique mental health needs, but female veterans, especially during the perinatal period, not only is there just your run-of-the-mill depression, anxiety, we have a higher incidence of PTSD among veterans, not only for combat trauma, but as well as military sexual trauma. So these are some of the things that we thought we could help address with our perinatal veterans. So we took the collaborative care approach and applied it to perinatal female veterans. So that is pregnant and postpartum and breastfeeding veterans. I believe we're the first program to apply it to such a large scale. There was one smaller program at another VA, but we've been able to kind of expand upon that and add to it. So we have a nurse care manager that track the measurement-based treatment. That's kind of one of the primary things that we tend to track with your GAD-7 for anxiety, your PHQ-9 for depression, and your PCL5 for PTSD. So I realize this is a very busy slide, so I'm gonna do my best to explain it. Any staff member can refer to not only our program, but to our program. Our nurse care manager is the main point of contact. I like to say they run the show, because they're the ones that contact the veterans. They're the ones that gather these measurements and do referrals. I'm gonna go through a little bit what each person does in the program, but they assess the mental health of the veteran at baseline. So whenever they were referred, then they touch base with them once per trimester, and then one time after 2 weeks after giving birth, and then every 2 months up to 12 months postpartum. Now, part of what they do is they do triage management. So they see what level of care is appropriate for them, and they can refer the patient to that level of care. So that can either be a specialty clinic. BHIP is our behavioral health interprofessional program. So that's more of our long-term mental health care for patients with more serious mental illness, as well as just patients that need to be seen on a longer-term basis than we can in collaborative care. And then they can also refer them to the patient-aligned care team, which is the primary care, or PCMHI is what I work for. It is primary care mental health integration. So we are mental health that is integrated into the primary care clinic, or we can also refer them to behavioral medicine. So the components of the program, we have program staff that can offer psychiatric medication management as well as psychotherapy, pharmacist that contacts every single veteran referred to us for a medication review. We also have dietitians that are available to discuss perinatal nutrition and lactation challenges during the postpartum and as well after pregnancy loss. We do have a weekly case management review, so kind of that registry review that is part of, excuse me, part of every collaborative care program. And we also have a monthly reproductive mental health committee, which is a little bit more overarching. That's not just kind of this program. And we also have the ability to do an e-consult to mainly tends to be the long-term psychiatrist for the patients. Sometimes primary care does take us up on that as well. So kind of the boss of the whole thing is our perinatal RN care manager. They do the comprehensive telephone assessment with the patient. They do care management throughout the pregnancy as well as postpartum. They offer referrals, resources, and education. They also manage the patient registry, which is not a small job. And they lead the weekly interprofessional registry review. And they're also the ones that tend to obtain the measures via assessment. If we see them as psychiatry, psychology, sometimes we can as well, but they tend to be the kind of the front line for us. So the maternity care coordinator is part of the VA San Diego healthcare system women's health team. So they are part of our program, but they tend to refer to us instead of the other way around. They're the ones that handle all the veterans' pregnancy needs, referring to an outside OB since we don't have OB-GYN care at the VA. And then referring to lactation consultants, doing all the referrals and following the patient throughout the pregnancy. They assess all the maternity-related needs. They can also provide resources and education. And as I mentioned, they follow throughout the entirety of the pregnancy. So we have a perinatal mental health psychologist as part of our team. We actually have a few of them. So they are a licensed provider that conducts differential diagnostic assessments when needed. They can also refer, there's going to be a few themes that most of us can do and is kind of in our wheelhouse. They also provide specialized psychotherapies when appropriate, whether that's for perinatal depression and anxiety, perinatal loss as well. And they are starting to run some groups as we start expanding our services a little bit. And they also participate in the weekly interprofessional review. And then we have the perinatal mental health psychiatrist, which is part of what I am. There's about 3 of us currently, 3.5. We have a fellow that's with us 2 days a week. So we all provide psychiatric assessment and medication recommendations when needed. We don't tend to manage the medications ourselves. We leave that to the primary psychiatrist, but we do make recommendations. One of the ways that we can do this is via an e-consult. So we don't always have to assess the patient if they just have kind of a general question about, what sleep medication can I use for a pregnant patient. They can consult us via e-consult, but we can also do a little bit more in-depth assessment in person or via telehealth, as it most of the time turns out to be. We can also offer preconception counseling to the patient on medications, as well as kind of loop in their primary psychiatrist and let them know our recommendations. And we also participate in the weekly registry review. So recently, within the last couple months, we just added a perinatal nutritionist, which we are more than happy to have aboard. They are able to discuss perinatal nutrition and lactation challenges during the postpartum period, as well as after pregnancy loss. Unfortunately, we have had some patients that have lost their pregnancy, and we are able to help them through that if they would like those services. They tend to focus on the nutrition of the mother instead of the nutrition of the fetus. And they also participate in our weekly review. So this is our referrals by month. It kind of varies. We haven't really found much rhyme or reason as to it yet, but the lowest was when we first started in January of 2021 was 6. And we've had a couple that have been above 20. Now, out of overall, that little box you see in the corner, we have 139 that are currently active. So we have 19 that have completed. So that means they've been referred to us, they've given birth, and they've gone through the 12 months of postpartum care and follow-up. We have about 75 that declined to participate in the program. 56 were incomplete. So a little bit of explanation. Incomplete means there was either a pregnancy loss or they moved away. A lot of times we get the veterans as soon as they get out of the military, and they tend to, San Diego's not the cheapest area to live in. So they'll move away to other more financially sustainable parts of the country that they can live in. And then, so that's for a grand total of 289 referrals we've had to date in the almost 2 years that we've been running the program. Referral sources. So about half of our referrals come from primary care, whether that's the primary care provider, primary care mental health integration, which is mental health collaborative clinic in primary care, or from the pharmacist in the primary care clinic. We do have about a quarter of them come from the maternity care coordinator, so the one that's in charge of kind of coordinating the maternity care for the patient, getting them connected with OB, getting them hooked up with whatever services they need. And general mental health actually is about a quarter of our referrals too, so that when they already have an established long-term psychiatrist, and then the patient finds out they're pregnant, or they're thinking about getting pregnant, they'll refer them to us for either some medication options that they can try, or how to handle the medications, or some preconception counseling. And a very small portion we've actually gotten referred to from intensive outpatient. So the timing, as you can tell, most of them do come to us during pregnancy, which is good because it gives us the longer opportunity to support the veterans throughout their pregnancy and throughout their postpartum. Ideally, we get them right at the beginning of pregnancy. That doesn't always happen, especially if it's an unplanned pregnancy, but the sooner we can get them, the better. And that's been pretty good. We've been able to do pretty good about that so far. Fertility difficulties is listed up there. We will get some referrals, mainly for psychological support. So our therapists will meet with some of the veterans that are having fertility difficulties and kind of help them process that distress. So the outcomes from the baseline referral, about a third of them continued with the current treatment they're having and didn't have any change in the treatment. But 42% were actually connected with new treatment, whether that's being referred to a psychiatrist, or being referred to our nutritionist, or being referred to one of our psychologists to get some additional therapy. 19% of them did decline, and 7% we were never able to get an outreach to, unfortunately. But the takeaway from this slide is about 3/4 of them almost either continued with their current treatment or were connected to new care via the program. Part of what we do at the is intermittently, but especially at the end of the program, when the patient's graduating, we send them a satisfaction survey. This includes some numerical values, as well as a place to give some feedback. So as you can tell, 0 is not helpful, 1 is somewhat helpful, 2 is very helpful, and 3 is extremely helpful. Overall, there's some pretty good satisfaction with the program. I've had a few that were not too keen on the program, but the majority of patients have been very happy with being able to participate in the program, as well as just the program overall, being able to be connected quicker to mental health practitioner, whether psychiatrist or psychologist, having that quicker access. Sometimes wait times in the VA and in private can be a little bit longer to get in to see mental health. We're able to get them in a little bit quicker via this program. So some constructive feedback we've had is that, we could provide the team members contact information at the initial visit. We could send a text message prior to a call, which I think is a really good one, because I don't always have my phone on me, but if I know the call's coming, they can prepare to answer and to be ready for it. And then also have the ability to email any concerns instead of relying on trying to play phone tag sometimes. Now, I hate reading long paragraphs off a presentation, but this is one time I'm going to break that rule, because I really like this piece of feedback, and it kind of reminds me of why we do this and why we do what we do. So I had a patient that said, made me feel like I had a support system. I felt like before I was in this program, I would fall between the cracks. I remember how I felt before during my pregnancy when I was referred over. I felt like this made a huge difference to me. I'm on meds now and receiving therapy. I'm proud of my decisions. I felt overwhelmed even during the process, and I was still supported. I wasn't embarrassed. You guys made it easier for me. Had the circumstances been different, I would be in an abusive relationship now. So that was one of our patients that was very happy with the program. And I got goosebumps reading that, because it kind of reminds me of this is why we do what we do. And this is why I'm so excited about this program. So moving into the future, We are still collecting measurement-based data. We haven't really collected enough to be able to present today, unfortunately. Pregnancy is not something we can really rush along, but we can, in the future, I'm hoping to be able to do some statistical analysis of that data, kind of see whether there's any significant changes in the depression, anxiety, and PTSD. My guess would be it'll probably be in line with normal treatment, but the access to care is what really makes this program stand out. We are also hoping to expand groups offered to veterans, such as new partners, perinatal loss, nutrition services for eating during pregnancy and eating in the postpartum. And one group that we're also trying to add is perinatal loss, not only for the female veterans, but also for their male partners, or mainly the male partners. We're having a male psychologist hopefully be able to add that in the future. We want to continue to expand our services and our staff. And down the road, we would probably like to add some substance use support during pregnancy and the postpartum as well. These are my references for my little bit of data I had, and I thank you for your time.
All right, thank you to our speakers for those wonderful presentations. So I'm going to open it up for questions, but before we do that, I just want to, for the sake of our colleagues who are watching this virtually and for those who are going to be watching the recorded session, if you do have a question, please use the microphone that's in the back, and same for our speakers. When you're answering your questions, please come up to the mic here. Oh, we have a microphone that we can also walk around with us. So yeah, if anybody has any questions, feel free to raise your hand. We can bring the microphone to you. Everybody did such fantastic presentations. We just have 0 questions. I actually have some questions myself. So for Dr. Saramele, you had mentioned the collaborative care arm had more patients than the co-occurring arm, and you had some theories on why that might be.
Oh,
Yeah.
yes, thank you.
Yeah.
I planted that question. I think in this trial we had patients in both arms were seen directly by psychiatrists. In the co-located arm, well, people were recruited into the study and then randomized, and if they went into the co-located arm, they were seen by a psychiatrist as the first contact. In the collaborative care arm, it was possible to see the psychiatrist first, but often the participants would see the care manager 1 time, 2 times. In other words, there were additional points of clinical contact and probably additional information that the psychiatrist had at the time of consultation that I think could have informed maybe diagnostic accuracy or increased clinical suspicion enough to say, yes, this is likely bipolar disorder. So I think that collaborative care may have influenced the diagnosis in that way.
Yeah.
Hi, as a follow-up to that, I was curious were you using the same psychiatrists for both the co-located and the collaborative care? Like, could theoretically one prescriber be working with both of those groups?
Yeah. This trial occurred in 3 states, and that varied a little bit by state. But there were some people who did see patients in both arms, some psychiatrists, and there were some psychiatrists who almost exclusively worked in one arm of the trial.
Thank you. I can keep going. I took notes. So for Dr. Zobler, so the study that you had looked at specifically looked at pain and depression. Are there any plans to kind of expand to other psychiatric comorbidities that can affect pain, like anxiety, trauma, or anything like that?
So yeah, this is one of many. We actually serve about 15 million lives in the platform. So we work with in a range of medical settings with a range of conditions. So we're looking at a range of outcome variables, a range of medical diagnoses. So there's a lot more to come. This was a study that we had done that what was particularly striking is the fact that we saw these digital only interventions really seem to make a significant difference, which is why we presented it here today. But there's a lot more to come. Yeah. Yeah.
I actually was wondering about the notification and monitoring process, especially in regards to urgent or crisis alerts that might have come up.
Yeah, thank you for that question. So anyone who scores positive on the 9th question of the PHQ-9, so they endorse any suicidality, triggers what we call an urgent alert. And when an urgent alert gets triggered, the patient immediately gets an email with crisis resources, and it's local resources, national resources, 988 line, a number of things. And then we have response service managers. These are usually master's prepared individuals who will then reach out to the patient, do a Columbia assessment, and then care coordinate based on the level of severity. So this all occurs at the time that urgent alert gets triggered, in between appointments. So that's how we do that. Yeah, just to try to ensure safety.
Oh, is that working?
There's a switch on.
Oh. I'll give you this.
Hi, I have a question for Dr. Plessia. I saw that the total cost and care increased to $200 over like 5 years. Was that like inflation adjusted, or is that?
I'd have to go back to the healthcare plan data, but I believe they did put it into 1 year dollar terms. So yes, I believe it was, but I'd have to confirm it. Thank you.
Then I have a question for Dr. Stewart. I have like twice the mics here. So you were going through kind of the numbers in terms of the referrals, and after the initial referrals are about 75 patients who didn't refused or denied the referral, and then like maybe another chunk that didn't want to follow through with treatment. Were there any reasons that came up about why they didn't want the referral, or like were we able to kind of follow up on like and maybe use that for how to recruit more in the future?
Yeah, it's a good question. There weren't any particular reasons why that kind of stood out. There were some that just said that they didn't feel that they needed to be a part of the program. I had some that said they felt like it would take up too much time, and despite me kind of explaining what the program entailed, they still felt like, no, it's just another call I'm gonna get from the VA, so I'm not interested at that time. But there wasn't just one overarching reason that we could identify.
Gotcha. So you received the referral, you still met with them just to kind of go over what it would entail?
So the nurse care manager would normally meet with them. The one where I met with them through the actually collaborative care clinic, and she was not interested in being referred to the perinatal mental health program.
Gotcha. All right. And then I guess the other question is, have there been any differences in referrals since post-ops, or not really?
Any difference in referrals since when?
Since post-ops, like the Dobbs versus Jackson decision that came out this summer?
That is a great question. I don't know that we've been able to really, we haven't noticed an uptick in it right now.
Sure.
I feel like that might be something that's coming down the road, because the data we had was right up until right around that time. I believe in the month that was reversed, but I would not be surprised if there was a uptick in referrals because of that.
Gotcha. Be curious. Oh, we have
Yep.
Well, I was just going to comment. I'm also at San Diego VA, but apparently I think federally abortions are going to be allowed, are going to be at VAs. And so it's unclear how that's going to be rolled out or how that will impact referrals to the program.
Thank you. Any other questions, comments, general thoughts? No? Well, I'll thank our speakers for their time and their interesting projects. And I'm sure they're available for questions if there are anything else that come up to y'all's minds, but thank you for attending our talk today.